Hi, I'm Dan Kindler. I trust I've been sufficiently introduced by the time you're seeing this. So let's get on with the show. I'm going to pull up my PowerPoint and over here and then get it to full screen and we're ready to go. Okay. So today we're going to be talking about microbes and mental illness, what every mental health worker should know about Lyme disease. I'll just preface this by saying that it's taken a long time for Western docs to acknowledge and understand to some extent that emotional issues, i.e. stress, can cause problems in our body, i.e. psychosomatic illness. Doctors still don't understand that organic and physical illness can cause emotional or neuropsychiatric symptoms. That's what we're going to be talking about today. So I really have nothing to disclose. Learning objectives, I'll let you read this at your leisure. And let's get started. So this 39-year-old female nurse, lovely, lovely woman, when she was 34 years old, she came down with the more or less sudden onset of anxiety and depression. No obvious triggering event, no family history. And that's what she had been treated for 5 years when she came to see me. But on taking a history, she had a bunch of other physical complaints: facial pain, headaches, palpitations, joint pains, paresthesias, which are pins and needles or neuropathic symptoms, night sweats, low-grade fevers, fatigue. She'd been tried on some psychotropic meds. She did not tolerate 3 of them: Lexapro, Effexor, Pristiq. Zoloft helped a bit. Well, it turned out she had Lyme disease. She had a co-infection, which we'll be talking about, babesiosis. She had multiple comorbidities. I call them upstream and downstream issues. Some preceded the Lyme disease and made it worse, and some occurred because of the chronic infection, the chronic inflammation associated with these infections. So she had low adrenal function. She had methylation mutations, which compromised her detoxification. Diabetes insipidus, in which case she was chronically dehydrated. She became sensitive to dairy products. Basically, after 2 years of treatment for her infections and her comorbidities, all her symptoms remitted. She was off all her medications, no anxiety, no depression. And to top it off, during the past 7 years, she's not only remained asymptomatic, but she's been offering support to other Lyme patients. Wonderful woman. So what are we talking about? What's chronic Lyme disease? There's 2 sets of people who fit into this category. There are those with a prior history of acute Lyme disease. They were treated with short-term antibiotics. So they might have gotten a bullseye rash, they've seen a tick bite, developed a flu syndrome, put on anything from 10 days to 3 weeks of doxycycline, but they either continue to be symptomatic or feel better and then have the recurrence of symptoms weeks, months, or years after treatment. These people are labeled PTLDS, post-treatment Lyme disease syndrome. This is a designation that I abhor. It suggests that the Lyme disease is no longer there and it's quote unquote something else. Well, it's not something else. It's still Lyme disease, but it's complicated because it's Lyme disease with co-infections. The other category is people who never knew they had a tick-borne infection. They never saw a tick attachment. They never, or if they did, it didn't cause any symptoms. They didn't see a rash. They didn't have the flu syndrome, or if they did, they thought it was maybe the flu. At any rate, over time, they developed chronic symptoms, which we will talk about. So all these patients who develop chronic symptoms in association with Lyme do have co-infections. So understand that the deer tick, also known as the black-legged tick, it is actually a menagerie of microbes. I would say more like a sewer of microbes. And it can transmit multiple infections. I've had patients with even 5 and 6 infections that are tick-borne. So you get multiple infections. Every patient I see who develops chronic symptoms in association with Lyme disease, every one of them has co-infections and sometimes multiple co-infections. And if they're sick for a long time, they have other issues. That these comorbidities include endocrine issues, becoming sensitive to food and mold and so on. I prefer to refer these patients to as Lyme disease complex. It's not just Lyme, it's co-infections, it's downstream issues and so on. 4 central points: Lyme disease complex often presents as a psychiatric illness or a major mood disorder accompanied by physical symptoms, just like the first patient. And think about it. Patient says, oh, I'm anxious and depressed, but I also have, muscle and joint pain. What's going to happen to that patient? They're going to be seen by a mental health worker. They're not going to get a big workup for their physical complaints. Pattern recognition is essential in the diagnosis. We'll describe the pattern. Testing for Lyme disease we'll go over. It is not straightforward. And this diagnosis of chronic Lyme is still not generally accepted by mainstream medicine, despite truly overwhelming evidence. So here's what the CDC and the Infectious Disease Society of America says. They do not acknowledge chronic Lyme disease. They cite 4 retreatment studies as proof of non-existence. So what's a retreatment study? They see people with the so-called PTLDS, they give them antibiotics and they don't get better. However, all 4 studies are significantly flawed. I mean, really flawed in design and execution, small sample size, significant selection bias, subtherapeutic dosing and length of treatment, and even failure to acknowledge the benefits of retreatment. 2 of the studies actually showed significant benefit, but not in the conclusions. One has to wonder whether these were designed to fail. In fact, there are over 300 published articles in the medical literature with evidence of persistent infection. Bad news is you have Lyme disease. Good news is I don't believe in that disease. You're fine. Why does Lyme persist? Well, here's a handful of reasons. These bugs, they really mess with us. For one thing, they suppress the immune system. We can't fight them so well. Sequestration in antibiotic privileged sites, areas where they avoid not only antibiotics, but even immune detection, like fibrous tissue. Biofilms. Biofilms refer to gelatinous membranes that encompass quorums of bacteria and viruses and protozoa. It's now generally accepted that chronic infections exist within these biofilm communities, and within these gelatinous matrices, it's hard for the immune system and antibiotics to access them. Atypical or cystic forms. So Borrelia burgdorferi, the microbe that causes Lyme disease, exists as a spirochete, but that spirochete can transform into a cyst. And in that cyst, it's more dormant, and it's not as easily recognized by our immune systems. Long replication cycles. Remember that antibiotics mainly hit microbes in their replication while they're replicating. And if there's a very long replication cycle, antibiotics are not going to be as effective. And here I think is the biggest issue, polymicrobial infections. The reason I say this is the biggest issue is because I don't see patients who don't have polymicrobial infections. They all have co-infections. Okay, so how prevalent is Lyme disease? In 2017, the CDC said that 42,000 new cases were reported to them. And they figured out, they did some research and made up an algorithm, and they said, okay, it's underreported by a factor of 10 to 1. Basically, most doctors don't bother reporting it, and therefore they suggested that there were 420,000 new cases in the United States. By the way, in 2020, they suggested 500,000 new cases in the United States. However, those cases are defined by the surveillance criteria. They have criteria, you can look it up, where people have to have certain laboratory parameters and so on. And if they don't, they're not included, even though they might clearly have Lyme disease. So it turns out that there are studies which compared how many people were reported compared to how many people were actually diagnosed with Lyme disease clinically in a doctor's office. And it suggested that actually this disease is underreported by a factor of 40 to 1, not 10 to 1. So take 40 times 500,000, and now you're talking about 2 million new cases. So there's clearly over 1 million new cases per year in the United States, and this has also been documented. It is now well accepted that 10 to 20% of those cases become chronically ill, and it may be as high as 50%. And by the way, we're only talking about people who've been diagnosed with acute Lyme disease. This doesn't even include the people who develop chronic Lyme without ever having been aware of an acute infection. Okay, where are you at risk? The highest, extremely high risk of exposure, the Northeast, Mid-Atlantic, Upper Midwest, or Great Lakes. A lot of people don't know that the first reported case in the United States was in Wisconsin, 1971. Pacific Northwest and Northern California, Northern Europe, Australia. What do those have in common? High humidity. Ticks like humidity. Moderate to significant risk, Southeast, Eastern Great Plains, Intermountain West. It's probably much worse than we know. Simply doctors aren't diagnosing it. Where's the safest state? I would move to New Mexico. It's really dry unless you go up into the mountains and you're living in, with lots of trees, but most of New Mexico is really dry. I practiced medicine in New Mexico for 6-7 years. And I saw maybe 5 cases of people who had actually acquired Lyme disease in New Mexico. But check it out, Lyme disease has been reported in all 50 states. There's nowhere you are totally immune, but there's certainly areas where you are much, much more likely to get Lyme. And there it is, there's a little bugger. And the key is little. It's really hard to see these dudes. And particularly because they tend to hide in intertriginous areas. So they're in the armpits, they're between the buttocks, they're in the groin. They like the warm, moist areas the most, but they might just be sitting on your breast or on your thigh. It's amazing. They crawl up your clothing. Okay. Prevalence in a psychiatric population. This is a recent study by Brian Fallon and colleagues at Columbia, a review of almost 7 million patients in Denmark over 22 years, found that patients who were diagnosed with Lyme had higher rates of mental health disorders, affective disorders, suicide attempts, and suicides. There was a study of a population of patients in a psychiatric hospital. They actually tested 900 some consecutive patients who were admitted to this hospital, and 1/3 of them were serologically positive for Lyme disease. A colleague of mine, Rosalie Greenberg, is a child psychiatrist in New Jersey who also happens to be Lyme literate. And of 69 patients who referred to her with whatever, children having neuropsychiatric issues, 49 out of 69, or 70% of them, tested positive to Lyme plus or minus a tick-borne co-infection. And in something similar, she looked at children who were referred to her diagnosed with pediatric bipolar disease. I know that's a somewhat controversial diagnosis, but 20 out of the 27, or 74%, tested positive to Lyme plus or minus tick-borne co-infections. There are over 400 peer-reviewed articles that document neuropsychiatric symptoms caused by Lyme. I've included these in handouts. And the clinical spectrum and pathophysiology is detailed by Robert Bransfield. And there is that citation. So what is the pathophysiology? Well, this of course is an oversimplification, but in general, these microbes don't invade cells and tissue, causing local inflammatory response to kill the microbe. So, we're not talking about strep throat or wound infection where we have the bugs invading tissue and then causing disruption of function in that tissue, and then a local inflammatory response, which cordons off the bug, kills the bug, and then repairs the tissue. Not what happens here. These microbes attack software, not hardware, not the cells themselves. They result in systemic inflammation and chaos in our regulatory system. So now the regulatory systems are off. The nervous system, both central and peripheral, the immune system causing immune suppression and autoimmunity, excess inflammation, endocrine system, particularly problems with adrenal, thyroid, and pituitary function. Neuroinflammation, brain inflammation results in psychiatric illness, otherwise something we call brain on fire. Okay, here's a list of conditions associated, psychiatric conditions associated with Lyme disease that are described in the literature. The top three: depression, anxiety disorders with panic attacks, irritability, anger, rage. These are by far the most common. Most of my patients will have complaints in these three categories. But guess what? A whole lot of other stuff has been described and is not uncommon. Bipolar, anhedonia, addictions, eating disorders, suicide, schizophrenia, schizoaffective disorder, depersonalization, personality disorders, dissociative episodes. Dissociative episodes are actually pretty common. I want to point out a couple important co-infections. Bartonella. Bartonella is another bacteria. It's a very common co-infection. Some people think it's actually more common than Lyme disease, but the testing for it is really inadequate. There's a lot of false negative in testing, and so it's just not as well recognized. But I can tell you, it causes the worst of the psychiatric disorders. Whenever I see someone come in where the mental health issue is so far and above all of the other complaints, as in maybe they're psychotic, maybe they're raging, excuse me, I always think Bartonella. So depression, anxiety, panic disorders, irritability, anger, rage, really the same things we see with Lyme, but maybe even worse. And it has been described that it can trigger PANS, pediatric acute onset neuropsychiatric syndrome. This is, I thought, an amazing study by my colleague Ed Breitschwert in North Carolina. He took 33 patients with recent onset neuropsychiatric symptoms. And here's where their main complaints, what I've already described, the depression, anxiety, and irritability, and a whole bunch of other complaints like sleep disorders, confusion, headaches, and so on. Okay, out of those 33, 29 of them had serological or PCR evidence. So serological is antibody, PCR evidence means they're actually seeing the bug, the DNA of the bug. And out of, well, let me just mention that if you took a control population, you might find 10 or 15% who also had serological evidence of Bartonella, and some even with PCR evidence, and they're not symptomatic. God bless them. But 29 out of 33, that's huge. And out of that 29, 24 of them had some skin lesions. Most of them were Bartonella stria. And if you biopsy these stria or lines, which I will show you, you can find the Bartonella bacteria. Here is a picture of Bartonella stria. It looks like this person's been whipped on the back. The Lyme deniers claim, oh, these are just routine stretch marks. Well, they're clearly not. And here is, this is a young woman who actually has PANS and Bartonella, and you can see the lines on the backs of her legs. Same patient, you can see the lines on her arm. Bartonella stria, we're going to come back to this with another patient. I want to talk to you about yet another co-infection, mycoplasma. Now, mycoplasma pneumonia is a common respiratory pathogen. It can cause anything from colds, sore throats, ear infections. It's a very common cause of bronchitis and pneumonia. So most of us have actually been in contact with mycoplasma pneumonia. Most of us will have some antibodies to it. It can also be tick-borne, and it can cause serious autoimmune and neurological disorders. What's been demonstrated in the medical literature is mycoplasma can cause psychosis, OCD, mania, and pediatric acute onset neuropsychiatric syndrome. I would say at least half of my patients with PANS have evidence of mycoplasma infection. So what is PANS? Pediatric acute onset neuropsychiatric syndrome was originally described after infections with streptococcus, and that's when it was labeled PANDAS, pediatric autoimmune neuropsychiatric disease associated with streptococcal infections. And what they're describing in these kids is that they're fine, they get a strep throat, and then they just fall off a cliff. They suddenly have the onset of severe neuropsychiatric problems. Well, now we know that it's not just strep. There are multiple infections, multiple microbes that can trigger this syndrome, including tick-borne infections. Definitely Bartonella, definitely mycoplasma, possibly Lyme, probably Babesia as well. There are criteria for PANS, and they're clinical criteria. The abrupt onset of either OCD or an eating disorder in a child, and it's usually eating restriction, anorexia. No known neurological disorder to account for these symptoms, and at least two of the following. Okay, anxiety is a separate criteria from mood swings or depression. I just couldn't fit that in separate lines. Irritability, aggression, rage, oppositional defiance disorder, behavioral developmental regression. Remember, we're talking about kids. Deterioration in school performance or impaired cognition, motor or sensory abnormalities, including tics, grimacing, or choreiform movements. The choreiform movements refer to involuntary movement. Suddenly their arms, their legs move and they're not willing it to happen. Somatic signs and symptoms. So these people have, they have pain syndromes, they have sleep problems, they have bedwetting and so on. What's the pathophysiology? Well, it's an autoimmune reaction causing inflammation in the brain. So basically, antibodies to these microbes, antibodies to the infection cross-react with host tissues, and in this case, they're engendering antineuronal antibodies. The antineuronal antibodies cross the blood-brain barrier. They stimulate an enzyme, calcium calmodulin protein kinase 2, just think of it as CAMK2, which in turn alters dopamine transmission, and there you have it, neuropsychiatric symptoms. There actually is a test for PANS. It's called the Cunningham panel after Madeline Cunningham. And it measures 4 of these antineuronal antibodies. It measures the activity of the CAMK2 enzyme. And there are a few studies which have demonstrated the utility of the Cunningham panel in diagnosing PANS. I want to point out that I really don't like the nomenclature of this syndrome. For one thing, PANS often does not have an acute presentation. In addition, it also occurs in adults. This is not just a pediatric problem, but in adults we call it autoimmune encephalopathy, which is what it is in children too, of course. Okay, I want to describe what happened in a study that we did here in Colorado. There is a residential treatment facility in Estes Park, Colorado, and they have adolescents there who can't hack it at home. We, at random, tested 10 of them. They all were diagnosed with major depressive disorder, 7 of them with generalized anxiety disorder, 3 of them had made serious suicide attempts, 4 were cutting, 1 had ticks, no known organic illness except 1 who was previously diagnosed with celiac disease. So all we did was draw blood on these 10 adolescents. 6 of the 10 had clear-cut antibodies to tick-borne infections, Lyme, Bartonella, and/or tick-borne relapsing fever. Those are the microbes we tested them to because that's what the laboratory agreed to do for free. Okay, depending on interpretation of the test, as many as 9 of the 10 had possible exposure to these tick-borne pathogens. In addition, 3 of 10 had antibodies to strep. And then we did the Cunningham panel, which remember looks at antineuronal antibodies and the CAMK2 enzyme activity. 9 of 10 had positive Cunningham panels. And here's what a Cunningham panel looks like. You can see anti-dopamine receptors, anti-lysoganglioside, anti-tubulin, and then the activity of CAMK2. This is a case history of a patient that I saw who came to me diagnosed with anorexia nervosa. And her history was this. She grew up in upstate New York. She did have multiple tick attachments, but no known problems with that. That is, she didn't develop anything that the parents or a doctor would have recognized as Lyme disease. But at 2 years old, she began unaccountably screaming and trichotillomania. I hadn't known of that term until I saw this patient, but hair pulling. But when I say hair pulling, I mean pulling her hair out. By 4 years old, she developed some social anxiety issues, but as she got older, it just became generalized anxiety and lots of irritability. By 12 years old, she was complaining of fatigue, sore throat, she had swollen glands. 14 years old, she gets another tick attachment and a small rash. It's not treated, but now symptoms are continuing to worsen. Now she has more fatigue, impaired cognition, postural lightheadedness, so she stands up and she feels like she's going to pass out. She has sleep problems and increasing anxiety, depression, irritability. And at 15 years old, she begins restricting her food intake and purging. And she is, of course, admitted to an eating disorder unit with suicidal thought with intent. She's diagnosed with anorexia nervosa. She's tried on both sertraline and fluoxetine. Those didn't work. As you know, they can increase suicidal ideation, particularly in adolescents. Aripiprazole did help somewhat. Basically, she was discharged on the aripiprazole, but she refused to eat, so they put in a nasogastric tube. She went in and out of the outpatient and inpatient units 5 times. Always admitted because she had suicidal thought with intent. And despite these 5 admissions, continued to refuse oral intake, despite intensive inpatient and outpatient psychotherapy, psychotropic meds, and behavioral interventions. Nothing was helping. So I saw her in my office, and on examination, she had 2 apparent issues on physical exam. One is that she had POTS. This is when you stand up and your heart starts racing, and it's associated with lightheadedness. It's a form of dysautonomia, autonomic nervous system dysregulation. And she had these Bartonella stria that we talked about previously. And here they are. She had these red lines on her thighs. Now here's the irony of this. She saw these red lines and she interpreted them as stretch marks and further evidence that she needed to lose weight. Isn't that ironic? Amazing. So her laboratory, she was positive for Lyme. She was positive for Babesia, very positive for Mycoplasma. She was negative for Bartonella, but as I mentioned previously, Bartonella is difficult to get positive testing on. It's just not very sensitive testing. But the Bartonella stria indicate, guess what? She's got Bartonella. Well, we treated her with antibiotics for a year. For 3 months, she was on intravenous antibiotics. And she went into total remission. She's been off treatment for 4 years and no recurrence of her eating disorder. It turns out there are a bunch of studies linking infections and eating disorders. So Riveri, or however one pronounces that, described an association of anorexia nervosa and other eating disorders with patients who had previously been on antibiotic, antiviral, and antifungal medications. Park and colleagues described 4 patients who experienced the onset of anorexia nervosa following viral infections. Simon described 4 young children who developed anorexia due to Epstein-Barr virus. Brauhaupt, this is another huge study out of Denmark. Basically, they followed a cohort of over 500,000 girls in Denmark over 27 years. And if they had been diagnosed and treated for an infection, they had an increased risk of anorexia nervosa by 23%, an increased risk of bulimia nervosa by 63%, and an increased risk of eating disorders that were not otherwise specified by 45%. Okay, so let's get to the root of, what do you folks do out there? How do you recognize Lyme disease in a psychiatric patient population? So here are the guidelines. You need a screening tool, you need a diagnostic test, and a referral network. This is a repeat slide. This is just to remind you. The psychiatric conditions associated with Lyme disease complex include, in particular, those first 3, anxiety disorders, depression, and irritability issues. But all of these others happen with some degree of frequency: OCD, phobias, schizoaffective disorder, bipolar disorder, eating disorders, anhedonia, addiction disorders, dissociative episodes, schizophrenia, personality disorders, and suicide. Suicide is the most common cause of death in patients with Lyme disease. Okay, so what would make you consider Lyme disease in a patient who presents with a neuropsychiatric condition? Well, here's some clues. Here's when, you should start to think about it. First of all, is it a kid? Why are we seeing so many kids who with, these anxiety disorders and depression and opposition and this and that? So early onset. And by the way, Lyme disease, Babesia, Bartonella, these all can be transmitted in utero. What if there's an absence of personal or family history, but this person goes bonkers? Okay, that's a clue. Poor or paradoxical response to medications, like the very first patient that I described. Excessive side effects and sensitivity to medications, not tolerating them. New onset of symptoms without psychological precipitants. Why did this 45-year-old previously well-adjusted male suddenly develop anxiety and depression out of the blue? But actually he went to Cape Cod that summer, right? So especially after geographic exposure to Lyme endemic areas, especially with simultaneous onset of somatic symptoms. So what are the somatic symptoms? Well, there's a really long list, but here are by far the most common somatic symptoms: fatigue, headaches, joint and muscle pains, neck pain, impaired cognition, sleep issues, and neuropathic pain. Far and away, these are the most common. Not everyone has them. Okay, consider Lyme disease in patients who have been misdiagnosed. And that's mostly what I see. Most of the patients that come to my office have Lyme disease complex. They've been sick for years or even decades. And these are the diagnoses they typically carry: chronic fatigue syndrome, fibromyalgia, autoimmune illnesses with mood disorders, mold toxin illness, chronic viral infections, malingerer. And, I should have pointed out that they're typically diagnosed simply as having chronic depression. Okay, I want to point out that you can get Lyme disease plus co-infections and be asymptomatic until there's a trigger. So for example, everything's going along fine, and suddenly after a mold exposure, everything goes south. Same thing can happen with head trauma, surgery, emotional stress, viral illnesses, including, by the way, SARS-CoV-2. Exposure to corticosteroids or biologicals. Remember that these drugs suppress the immune system. Bugs come out to party. Vaccines This is really sad. I have seen this a number of times where people are doing pretty well and they get a vaccine, they're no longer doing well. Exposure to high altitude. Lyme bacteria are classified as facultative anaerobes. They prefer low oxygen tension, and they'll come out and party when you go up to Vail, Colorado. Okay, so what's the screening tool? I recommend a really good symptom questionnaire. So Dr. Joseph Burrascano is, I think, an icon in the Lyme world. He developed something called the Burrascano Guidelines and updated it every 5 years. Now, it hasn't been updated for about 15 years, but it's really an excellent document for free online. And there's a symptom questionnaire that I use to this day with my patients. And I'm pointing out again, here are the most common symptoms you will see in this patient population: fatigue, sleep problems, impaired cognition, headaches, muscle and joint pains, neck pain, neuropathic pains, mood disorders. Okay, I'm coming back to co-infections. Co-infections increase the severity of symptoms to make treatment more difficult. Basically, those 3 weeks of doxycycline, if you have Lyme plus a co-infection, no way that's going to cure it. And some of these co-infections cause more severe neuropsychiatric issues than Lyme disease. Really, when I see severe neuropsychiatric symptoms, I know more than Lyme is going on. And the two microbes that cause the most neuropsychiatric symptoms are Babesia and Bartonella. Babesia is quite common. It's not a bacteria, it's a protozoa. It's in the same family as malaria. And these are symptoms that would make one suspect Babesia: headaches, migraines, night sweats, chills, temperature intolerance, air hunger, neuropathy, dysautonomia. I should mention, low-grade fevers. Bartonella causes the worst in the way of neuropsychiatric symptoms. Also very common. More than half of my patients have Bartonella. And it causes the most severe neurological symptoms, including neuropsychiatric issues. So these are the people who have severe neuropathic pain, severe cognitive disorders, and so on. And they're the ones with these skin reactions that may include these stria, which are typically mistaken for stretch marks. Okay, how do we test for Lyme disease complex? I want to point out that most commercial laboratories do not do a good job. So first of all, understand that the CDC has these criteria for positivity, and they state these are for surveillance use only. They're not supposed to be used in the clinician's office. However, that's what most physicians do. They use the CDC criteria, never intended for that. And not only that, but because the CDC has made these criteria, the laboratories don't even print out, they don't even do all the testing that they can do. Finally, the screening tests recommended by the CDC and the Infectious Disease Society of America is the Lyme ELISA, enzyme-linked immunosorbent assay. This screening test has a false negativity rate greater than 50%. Think about it. Really, a screening test which could really provide a big net, and if anything, only have some false positives, instead has over 50% false negatives. Imagine a pregnancy test like this. Why is this still on the market, right? Well, consider who's making the recommendations, and consider who has the patents, and there'll be a lot of overlap. So I use IGeneX Laboratories. All they do is tick-borne disease testing. There are a few other good laboratories. IGeneX is not the only one, but I have far and away the most experience with them. They've been doing this for a long time. I don't recommend Quest, LabCorp, Mayo, Vibrant, DNA Connections, and so on. The test results need to be interpreted by a Lyme literate doc. Don't just accept a positive or a negative. There are certain criteria that are going to be used by a laboratory to maintain credibility, but that doesn't mean that those criteria are going to include everyone who's positive. So that said, I would start off, if you're suspecting someone has Lyme disease complex, order the IGeneX Lyme Immunoblot, IgM and IgG, and I wrote down the test codes, and the cost is $450. If people have Medicare, everything is covered at IGeneX. And then develop a relationship with the Lyme literate doc who will assist in interpreting the lab and to make referrals. I think it's a great idea if you can go ahead and test for Babesia and Bartonella, but I can tell you the routine labs like Quest and LabCorp, where it would probably be covered, it's simply not, it's a very low sensitive test. Mostly I make the diagnosis clinically, but if the patient can afford it, I will order it at IGeneX as well. Here we go. This is in Massachusetts. Lyme test negative. It may still be Lyme disease. Good to know. So if you have a patient who says, oh yeah, I was tested for Lyme disease, it was negative, don't accept that. Okay, so the Western blot, which is the next test after a Lyme ELISA test, which is now graduated or evolved to the immunoblot, which is a more sensitive test than the Western blot, but is essentially measuring the same thing. They can be counterintuitive and often misinterpreted, and here's why. We're looking at antibodies to proteins in the Lyme spirochete. IgM, the IgM antibody is referred to as an acute phase antibody. If you Wikipedia IgM, it'll refer to IgM detection occurring within 2 weeks of infection. And then within 4 weeks of infection, it starts going down as IgG starts to rise. And IgG then takes over. That's called seroconversion, IgM to IgG. However, that's not what happens with Lyme disease. And it's not what happens with quite a few other infections, not only Lyme, which is IgM positivity can reflect persistent infection, not just recent infection. So consider the fact that mostly I see patients who've been sick for years or decades before they've seen me. They have not been treated. And when we test them, we typically see IgM positivity disproportionate to IgG. So classically, the IgG starts to rise 4 weeks after infection, but it may stay negative if the patient is untreated. If you're doing the Lyme immunoblot, which I recommend, the band 31, this is an antibody to an outer surface protein on the Lyme spirochete, is 100% Lyme. But there are other bands, antibodies to other proteins that are mostly specific. And there they are, 23, 25, 34, 39, 83, 93. The most sensitive band is typically 41. It's an antibody to a flagellar protein. It's not specific. You know, we like to see it, but we can't hang our hats on it. And then, as you will see, IGeneX will report indeterminate bands. And what this means is there was reactivity. There was something there, but it wasn't not as strong as the positive control. Therefore, they can't describe it as positive. You will see that these generally occur on Lyme-specific bands. I've looked at thousands of these. I interpret the indeterminates as positive, and so do most Lyme literate doctors. Okay, so persistent IgM, like I said, so important. IgM positivity typically occurs in chronic untreated infections, but guess what? If this person's seen an infectious disease doc and the infectious disease doc sees positive IgM, they say, it's clearly a false positive, you don't have Lyme disease. They don't know the medical literature. The sicker the patient, the more their immune system is suppressed and the less likely they are to have a positive antibody test. So this is not a 100% test, but it's pretty damn good. The not as sick patients more likely have positive tests, lots of antibodies. And I want to point out bands 31 and 34, these are two outer surface proteins. They will be positive if someone got the Lyme vaccine, which was back in 2000 and 2002. And also, first of all, people will know whether they got vaccinated, but also if they were infected if they're positive, it means, and they weren't vaccinated, that means that they've been infected for at least a year. These bands do not turn positive for at least a year. Okay, I'm going to show you some immunoblots. Ned was, he was sick for about a decade. He was diagnosed with chronic fatigue syndrome. He was having enough cognitive complaints that he stopped working. He was seen at Mayo Clinic, and they said, oh, you just have anxiety. So I actually met Ned on a camping trip. And so we were talking, and he told me how he had, retired because he just couldn't hack it with his chronic fatigue syndrome. And I suggested he get tested, and eventually he did. And check it out. Okay, so he has positive bands, 30, not specific, 31, specific, 34 and 39, they're very specific. He was indeterminate, 41, most sensitive, 83, 93, indeterminate, fairly specific, 23, 25, fairly specific. And you can see he had some IgG antibodies as well. He'd been sick for probably a decade with all of these symptoms. He had Lyme disease. He also, by the way, had babesiosis. He's fine now. He's great. Chris was 41 years old when I first saw him. And he was a Boulderite, typical Boulder guy. He was an executive. He'd get on his bike and ride 100 miles and everything was fine. He goes to Arizona, stays in this house, and he crashes for the next 2 years. He's just totally crashed. And when he came in to see me, this is what his Lyme test showed. You can see he's positive in Lyme specific bands, 31, 34, 39, 83, 93, 23, 25. It turns out, by the way, that that house that he lived in, it wasn't tick infested, it was moldy. So he had had dormant infections. And then when he was exposed to this big mold exposure, that's when he crashed. And we figured that out later when, after he was all better, he went and stayed in that house again. He was down for 2 months. It took us 2 months to get him back. Okay, Abby. So this is someone who did not have chronic Lyme. She did not have neuropsych symptoms, but she had a recent rash. She had been in New Hampshire, and her pediatrician here in Colorado refused to even test her for Lyme disease, which is not uncommon around here. And check it out, there she is. She has positive antibodies. Again, I'm including the indeterminates to 31, 39, 83, 93, 23, 25. She had Lyme. She actually also had babesia, and she also had Bartonella. Okay, I'm not going to spend time on testing for co-infections. I left it in here for you guys to look at. Suffice it to say that if you're serious about testing for babesia and Bartonella, I would use IGeneX. I think they do a much, much better job than your standard commercial laboratories like Quest and LabCorp, but they're still not 100%. I still mostly diagnose this clinically on the basis of symptom presentation and on the basis of response to treatment. Okay, and I just want to remind you that if these people have been sick for a long time with these chronic infections and chronic inflammatory disorders, there's a lot of other stuff that goes wrong. They typically develop multiple sensitivity syndromes to foods, particularly gluten, dairy, eggs, sugar, and yeast. They develop particularly candida issues, multiple chemical sensitivity syndromes, mold sensitivities, mast cell activation syndrome. Any one of these topics we could spend another hour on, right? They might have issues with mold toxins and heavy metal toxins, which on their own can dysregulate the nervous, immune, and endocrine systems, making it harder to treat the infections, as well as contributing to systemic inflammation. More often than not, at least half my patients have endocrinopathies, low adrenal function, thyroid abnormalities, pituitary problems, particularly with diabetes insipidus, low testosterone levels, a whole host of gastrointestinal issues. So here we go. Here's the crux of this lecture. How do we recognize Lyme disease in a psychiatric patient population? This is the most important slide in this lecture, folks. I want you to consider Lyme disease complex in all of your patients who have this. Okay, These diagnoses, particularly the top three, anxiety, depression, irritability, anger, rage issues, but you remember that slide that listed a whole lot of other issues such as bipolar illness and eating disorders. Okay, so here you have someone with neuropsychiatric problems, but when you start asking, well, it turns out they also have other symptoms like fatigue, impaired cognition, muscle, joint pain, sleep disorder, headaches, neck pain. Okay, this should really raise your level of suspicion and or these characteristics, treatment resistance, they don't do well on the drugs. Early onset, why is this kid suddenly so nuts? You know, these aren't regular temper tantrums, these are meltdowns. Sudden onset without an obvious trigger. Why did suddenly this really nice, well-adjusted teenager like totally lose it? Exposure to a Lyme endemic area, lack of personal or family psych history. And again, excessive side effects, sensitivity or paradoxical reactions to psychotropic medications. It's not true in all of them, it's true in a lot of them. Okay, what do you do? Well, develop a referral network. ILADS is the International Lyme and Associated Diseases Society, and you can find Lyme litter providers in your area and develop a relationship. I would suggest finding someone who uses an individualized treatment approach. You cannot apply a cookbook approach to these patients. Everyone needs to have individualized treatment. Look for an integrative approach. I don't know how it can be done just with allopathic drugs. And what can you expect? I don't tell people we can cure them, not once they're in a chronic stage, but we can get them all better, which I call remission, not cure. 85 to 90% of my patients feel 85 to 100% better with appropriate treatment. And it can take time. It can take years, actually, but people do get better over time. Arthur Schopenhauer, first the truth is ridiculed, then it meets outrage, then it is said to have been obvious all along. Well, folks, you know, I'm hoping that spreading the word will make it more obvious to those who are denying this problem. I think it is incredibly important. I appreciate your listening to this and going forth and being more aware of this problem. And finally, I want to thank Dr. Nancy Brown for her contribution to this presentation. So thank you very much. I wish I was there to take questions, and maybe if you do have questions I can answer, you can pass them on to Dr. Greenblatt. I did write a book on Lyme disease that came out this, well, by the time you hear this, it'll be last year. And that's more likely than not will answer all your questions. So thanks very much for your attention. I look forward to the next lecture, which is on PANS, Pediatric Acute Onset Neuropsychiatric Syndrome. Be well, take care.